Today's video is mainly demonstrating or instructing or giving just a way of doing shoulder assessments, and it is brief way of understanding the shoulder assessments. A lot of people have confusion that if we are doing shoulder assessment, what should we do and how should we begin it. So first and foremost thing which we always do in shoulder examination is that you have to take subjective history, and you have to screen for red flags. Screening for red flags is very important, because if we don't screen for red flags, we will not know whether the physical therapist can take the patient or we need to refer the patient to some other fraternity of doctors. So first of all, what we have to do is you have to ask history. So today's video is just mainly for the shoulder. I am explaining for the shoulder purpose, and if you really want to be a skilled physical therapist, what is required is the knowledge of anatomy. For example, if you're dealing with shoulder complex, you need to know that what all structures are involved in shoulder. So coming back to the assessment portion, first is subjective history. So you're going to ask about the onset of pain, the relieving factors, the aggravating factors, whether there was any traumatic incident which has caused the pain, whether it was gradual, okay, whether there is some cervical involvement present along with shoulder pain or not, and why all these questions are important. Whenever you are asking in history whether the onset was gradual or sudden, whether it was traumatic or whether it is due to overuse, your mind should be going to different directions. For example, I have got a patient who has got a traumatic history and then the shoulder pain has started. My mind should automatically go towards the rotator cuff tears or rotator cuff issues, something like that. If I have a patient who has got pain due to overuse, it might be due to tendinopathy or some subacromial pain syndrome. If I have got a patient who has got cervical involvement, along with that there is a shoulder pain, then I have to correlate whether it is the cervical issue which is causing the shoulder pain, or the shoulder pain biomechanical changes is causing the cervical pain. So we have to look for that. Then we have to always look for red flags. For example, in the history, if the patient says that there was sudden weight loss, or there was sudden fevers, or there was chills and there was malignancy, if the patient complains of any deformity, or you visually see any deformity, we have to consider that to be red flags. After doing the subjective examination portion, the history should include everything related to if there was any surgery done on that shoulder, or if there was some cervical surgery done. Most of the students get confused that in surgical history, is the knee history related when we are doing the shoulder assessment? No. If you are taking shoulder assessment and the patient has come to you just for shoulder assessment and not any other thing, the knee operation is not to be included in your surgical history. Next, second portion is range of motion and strength testing. So range of motions, we generally do active range of motion and passive range of motion. And active and passive range of motions never should be said that by visually looking at that it is 160 degree or 180 degree or 60 degrees or 120 degrees. Never do that. We have got goniometers, we have got inclinometers, and in this Gen Z's world, we have also got something smartphone assistive devices. Always look for proper range of motion angles, as we will be treating the patient, and we need to know that whatever treatment we are giving, whether it is going in a right direction or not, whether the range that the patient came for in the first day, is it improving or not. So we need to see that. Also, one thing which I just missed telling you in the subjective history portion is always ask about psychosocial factors, because psychosocial factors also play an important role in your say treatment. Because if the patient has come with a certain notion in mind that if I'm going to do the physical therapy, this is the problem which I'm going to encounter, like I'll get a shock, or the patient has come with that fear that the things might go wrong. So we need to look into consideration the psychosocial factors. Coming to the third point, which is the resisted isometric testing. It is important because resisted isometric testing will tell you whether when you are doing the movement, whether it is weak painful, weak pain-free, strong painful, strong pain-free. Deciding on those 4 criteria, you will be able to know whether your patient has just got weakness, whether your patient has got neuropathies, whether your patient has got tears. After doing that, the fifth, if I'm not missing the count, the fourth portion is the special test. So there are a numerous number of special tests given in the books, but you have to decide that which special test has to be done. For example, say subacromial pain syndrome. For subacromial pain syndrome, you have got n list or list of special tests in your book. So not every special test has to be performed. For example, if you're looking for subacromial pain syndrome, go for painful arc, go for Hawkins-Kennedy's. I think that is enough. Then if you are not getting anything, and always when you have already taken the history, when you have taken the range of motion, when you have taken resisted, you would have certain differential diagnosis in your mind. Based on that, you have to go for special test. Every special test given in the chapter of shoulder should not be done on patient. You have to decide between that what is your differential diagnosis. For example, I want to rule between subacromial pain syndrome, biceps tendinopathy and rotator cuff tear. Then you have to just focus on those special tests. For example, I'll do Hawkins-Kennedy, painful arc, drop arm and speeds test. For me, that will lead me to some of the diagnosis. And lastly, when you are coming to a clinical summary, the clinical summary cannot be decided just based on the history, just based on the special test, or just based on the range of motion and isometric testing. It has to be a correlation of all. For example, my patient is getting positive test for, say, Hawkins-Kennedy's knee impingement and painful arc. I can go for subacromial. If my patient is having positive for, say, drop arm, external rotation lag sign, I can go for the rotator cuff tears. If my patient is having positive for speeds and Yergasons, I can go for biceps tendinopathy. But that has to be correlated with your history and your range of motions testing. This is just a brief about how you take shoulder examination. I will just drop down a book which I have referred for examinations. It is always, there is no book which is going to tell you that do this examination exactly like this. What you have to figure out is, this is the basics. The basics for every joint is this. It will just differ based on your anatomy, based on what do you want to see in that patient, and whether it is correlating clinically or not. It just depends on that. If you have any queries, drop down below. I'll be happy to help you, and this is the book. Happy learning.